back to the Worcester Senior Center Stay Connected programming on Channel 192. My name is Suki Lapin, and I am the program coordinator at the Worcester Senior Center. In honor of Heart Month, today we are fortunate to honor once again Dr. Bryon Gentile, echocardiologist at UMass Medical Group. Joe Fish, one of our beloved Worcester Senior Center exercise instructors, is also here to introduce his Heart Healthy Exercise program, which will also air this month. And he is here to introduce his longtime family friend, Dr. Bryon Gentile, your beloved Worcester Senior Center exercise instructor, Joe Fish.
Thank you, Suki. I'll be doing a new healthy heart exercise class coming up soon on video. And it's so good to be with you all today during Healthy Heart Month. Today I have the honor of introducing our distinguished speaker for this event, Dr. Bryon Gentile. Dr. Gentile is a cardiologist with the UMass Medical Group, and today he'll be discussing atrial fibrillation and blood thinners. Well, please welcome Dr. Bryon Gentile.
Thank you, Joe, for that kind introduction. It's my pleasure to be with you again this year for Heart Month. And this year we're going to be talking about atrial fibrillation, anticoagulation, which means blood thinning, and alternatives. As Joe mentioned, I'm a cardiologist at UMass Memorial Medical Center. I'm an assistant professor of medicine in the University of Massachusetts Medical School, and I am the co-director of the left atrial appendage occlusion program, as well as director of interventional echocardiography. So today we'll be talking about AFib, as you commonly know it, and blood thinners as well as their alternatives. So thanks again for joining me. I hope you enjoy our program. So before we talk about atrial fibrillation, we have to understand what normal sinus rhythm is. So normal sinus rhythm is the normal rhythm of the heart. It's electricity traveling from the top of the heart in what's called the SA node down to the bottom of the heart through a gatekeeper called the AV node. And this electrical system allows the top chambers to contract in unison and the bottom chambers to contract in unison, pumping blood out to the body. So what is atrial fibrillation? It's these irregular electrical signals in the top chambers, the atria, which causes them to quiver. That's called fibrillation. As a result, the heart can beat rapidly and irregularly, which prevents blood from effectively moving from the top chambers, the atria, to the bottom chambers, the ventricles. So you might ask, well, how common is this? Is this something that we really need to know about? And it turns out that this is the most common sustained arrhythmia worldwide. And arrhythmia is an irregular heart rhythm. So this is the most common sustained one worldwide. And about 20 years ago, or 21 years ago now, there were 5 million people in the United States that had atrial fibrillation, or AFib for short, and about 33 million people worldwide. And that continues to increase. Okay, so this was a study out of Minnesota that actually projected how many people in the United States are going to have AFib. And by the year 2050, it's estimated that somewhere between 12 and 16 million people in the US alone will have AFib. Now, I actually expect it's going to be more than that. And why is that? Well, we all have new technology, such as the iWatch. And the iWatch has found more and more episodes of atrial fibrillation. So I think that we're going to find more AFib than we previously thought. So what are some of the risk factors that predispose you to developing atrial fibrillation? So it turns out that the risk certainly increases with age. So as we get older, particularly in our 60s, 70s, and 80s, the risk of AFib goes up exponentially. Now, why might someone develop AFib? What are the associations? Well, there's an association with high blood pressure or hypertensive heart disease, coronary heart disease or congestive heart failure, Some patients that have problems with their heart valves, such as mitral stenosis or regurgitation, which means leakiness, okay, can develop AFib. As I mentioned, congestive heart failure, but it's not just issues that are related to the heart. It can be lung disease. So patients with COPD, it's pretty common to develop AFib, sleep apnea, kidney disease, diabetes. Now, there are some reversible causes. So some patients that have an overactive thyroid called hyperthyroidism will go on to develop AFib. Those that consume alcohol excessively, particularly those that participate in binge drinking, are more likely to develop AFib. And those that have open heart surgery can certainly develop AFib. Now, many of my patients say, well, I have a relative that has AFib. Does that mean I'm going to develop AFib? And that's less well defined. There are some associations between first-degree relatives, but we have not isolated a single gene that transmits AFib. So the genetics are not well isolated yet. Now, how about caffeine? I know my patients come in and ask, well, I have a cup of coffee every day. Is that going to give me AFib? And that's not well defined. There has not been a clear link between caffeine consumption and this irregular heart rhythm. So many of my patients say, well, how do I know if I have AFib? And it turns out that there's a wide range of symptoms. Some patients describe irregular heartbeats or a fast racing heart that we refer to as palpitations. Other patients say that they feel tired or fatigued. Some say they have lightheadedness. Others say they have shortness of breath. Some even tell me that they have chest discomfort. And when they say that, they say, hey, it kind of feels like I have a fish flopping on the beach inside of my chest. Other patients have reported fainting or passing out, and some even report confusion. So why do we worry about AFib? And the real reason we worry about it is there's some risks associated with it. So the major risk that you'll read about, which perhaps you've seen on the internet or you heard us talk about before, is stroke, okay? And what happens as those top chambers quiver, blood doesn't empty out of the heart completely. And when blood doesn't empty completely, clot formation within the heart can happen. And we refer to that as a thrombus, okay? And because the heart is an organ that pumps blood, that clot can be ejected from the heart. And that's referred to as an embolism. And that clot being ejected from the heart can go to a few different places. Most commonly, it goes to the brain. And when it does that, we refer to it as a stroke, but it can go to the legs, it can go to the kidneys, it can go to the spleen, or it can go to any of the organs of the body. You'll also hear sometimes people talking about a heart attack from AFib, and that's less common, but sometimes we see when the heart is beating so fast, the demand or the amount of blood that the heart wants exceeds the supply. So certainly there are some risks, the major risk being stroke. I'm going to play a video for you here.
Nearly 1 out of 3 AFib patients will have a stroke. But why are they more likely to have a stroke than people without AFib? For patients with AFib, over 90% of stroke-causing clots that originate in the heart are formed in a structure called the left atrial appendage, or LAA. Everyone has a left atrial appendage. It is a small pouch that sits off of the left side of your heart. AFib may cause the blood being pumped through your heart to pool in the LAA, where it gets stuck and can form a clot. If that clot escapes and gets into your circulatory system, it can block the blood supply to the brain and may cause a stroke.
So how do we quantify this risk of a stroke? Well, most commonly, cardiologists and other doctors look at a scoring system called the CHADS-2 VASC score. And that looks at risk factors like congestive heart failure or reduced pumping function of the heart. Things like high blood pressure, age is certainly a factor, diabetes, prior stroke, mini stroke, or blood clot, sort of disease in the vascular system, whether it's the aorta or the carotid arteries in the neck, and then being a woman confers a risk. And so what we do is we tally up these points, okay? And notice as these points increase, the risk of stroke per year goes up. So how do we treat AFib? There are 2 different things that we think about with every patient with AFib. So we think about first controlling the irregular heart rhythm or the arrhythmia, and more importantly, preventing stroke. Controlling the arrhythmia, there can be a variety of different treatment options. The main course is to control the rapid heart rates because that's what patients find to be most uncomfortable. So we can do that through medications such as beta blockers, which you may know as metoprolol, atenolol, carvedilol, there are a few others, or calcium channel blockers. You may have heard of these such as diltiazem or verapamil. And those agents really slow down the heart rate and prevent it from going too fast. What we can do is get you out of the irregular heart rhythm, out of the arrhythmia, and we call that restoring normal sinus rhythm. And we can do that with what's called a cardioversion. You may have heard of this. This is where we shock the heart back into normal rhythm. We can also do this through medications that convert the heart back into normal rhythm. And one of the more common ones is flecainide. Now, once we get you back into normal rhythm, we try to keep you in normal rhythm. And we can do that with different medications. You may have heard of some of these, dofetilide, which is also called Tikecin, sotalol, or amiodarone. And some of you may have even heard about a procedure called a catheter-based ablation, where we try to prevent the AFib from coming back. Okay? In other patients, all we do is simply control the rapid heart rates because they have no symptoms from the atrial fibrillation. Okay? Now, the key is really in preventing stroke. Now, this is a picture of that left atrial appendage that you just saw in that video. And this is a blood clot that has formed inside the left atrial appendage. So how do we prevent that? Well, we can do that through medications, okay? Or we can do that through a procedure called left atrial appendage closure. Now, most commonly, my patients say, well, I take an aspirin every day. Will that protect me from stroke? And the answer is aspirin does not do a very good job in preventing stroke in patients with AFib. So this was a study that looked at aspirin versus blood thinners. And these are, as this goes up, the more strokes there are. And notice in patients taking aspirin, there were more strokes than compared to those who were taking blood thinners such as Warfarin. So let's talk a little bit about Warfarin. Many of you know this as Coumadin, right? This is a blood thinner, and it works by inhibiting vitamin K inside of your body. So what the Warfarin does is it prevents vitamin K from being converted into an active form, and by doing so, it thins the blood. Now, what are some of the pros and cons of Warfarin? Well, the pro is the cost. Warfarin has been around for many, many years. And so as a result, the price is very, very inexpensive. It's very effective. Okay, we've been treating patients with this medication for a long time. It has a long half-life, which means that in the event that you were to miss a dose, your blood would still be thin. And importantly, it can be reversed with vitamin K and other blood products. So the reversal of this blood thinner has been established for a long, long time. Now, Warfarin, like any other medication, is a double-edged sword. What are the cons? Well, you need to monitor Warfarin, and we'll talk about that in a minute. It's affected by diet. So if you're eating foods that are rich in vitamin K, Warfarin's not going to be as effective. So you'll hear us tell our patients that they need to watch the leafy green vegetables they eat, such as broccoli. There's a lot of vitamin K in that. It will require frequent dosing adjustments depending on your Warfarin level. As with all blood thinners, okay, there is a risk of bleeding. And then finally, it has a slow onset of action. So what that means is the dose of Warfarin that you take today, we won't really see the effects of that dose for a few days. So talking about Warfarin, you have to follow levels. So what we aim for is something called an INR, which is an international normalized ratio, okay? And that is how thin the blood is. And with most patients with AFib, we try to keep their INR between 2 and 3. That's what's referred to as a therapeutic range. If your INR is less than 2, that means you're under anticoagulated or the blood is too thick and you're at increased risk of stroke. Whereas if your INR is over 3, you're over anticoagulated. The blood is too thin. you're at risk of bleeding. So it's really key to stay in this range of 2 to 3. So how do we do in keeping patients in that normal range? Now, an anticoagulation clinic that has a time and therapeutic range of 70%, which means 70% of the time you're between 2 and 3, that's a very good time and therapeutic range. And our UMass anticoagulation clinic actually does a little bit better than that. Their time and therapeutic range is almost 80%, actually. But what this graph shows is that as that stroke risk goes up, so that Chad's VASC score is increasing, the time and therapeutic range actually goes down. So why is that? Well, think about all the things that were in that score. So other medical conditions such as heart failure, diabetes, prior stroke, patients are sicker. So as patients get sicker, they're on other medications that tend to interact with warfarin, or they may be hospitalized with pneumonia, and things like antibiotics affect warfarin. So it affects your time in that targeted range. So not only does our time in that targeted range, we as physicians tend to prescribe anticoagulants less as that stroke risk goes up. And why is that? It's for the same reason that we just discussed, right? Patients get sicker as that score goes up. So maybe they're falling, maybe they're bleeding, maybe they're having intestinal issues. So it turns out across the world, less prescriptions for anticoagulants are written as the stroke risk goes up. So some say, well, there are big limitations with warfarin. Are there other alternatives to warfarin? And there are. These are what are referred to as the direct oral anticoagulants, okay, or DOACs. Some people refer to them as NOACs, which are novel oral anticoagulants. So the same terminology used interchangeably. And these medications include dabigatran, which is, the brand is Pradaxa, rivaroxaban, the brand is Xarelto, apixaban, the brand is Eliquis, and edoxaban, the brand is Cyasa. So what are the pros and cons of these direct oral anticoagulants? These are very, very effective, and they're quick on and quick off. Now that's important. That means as you take them, they work. But if you miss a dose, they don't work. So they really only work when taken as prescribed, as opposed to warfarin, because of its long half-life. If you miss a dose, the blood is still generally thin, okay? One of the other pros is that routine monitoring is not required, and these medications are not affected by diets. So my patients can eat all the leafy green vegetables that they want. Now, what are the cons? Well, these often are quite pricey, and the coverage depends on your insurance plan. They're not yet generic, although we're hopeful that in the coming years they're going to become generic. One of the other cons is that the dosing is affected by kidney function. Okay, whereas warfarin is not affected by kidney function, these medications, the dosage is affected by kidney function. Now, just like warfarin, bleeding is a risk. These reversal agents for these medications are newer. They do exist, and yes, we have them at UMass. So if you were in a car accident when taking one of these medications, we do have the ability to reverse it. But it's important to know that these newer medications are not for patients with mechanical heart valves. So if you've had a heart valve replacement that's mechanical or metal, these are not intended for you. So naturally, that begs the question, well, which is better, the DOACs or warfarin? And so what this study looked at was stroke or blood clots traveling to other organs of the body, okay? And this would favor those DOACs, also called NOACs. These would favor warfarin. So the studies show that with these newer agents, there are fewer strokes or blood clots with the direct oral anticoagulants. And as a result, the American College of Cardiology and the American Heart Association now recommend these NOACs or DOACs are recommended over warfarin in eligible patients. So if you have a mechanical heart valve, you're not eligible, or if you have mitral stenosis, you're not eligible for these medications. So how do patients do in the clinical trials? Well, it turns out that in all these clinical trials, about a quarter of all patients end up stopping their blood thinner. And why is that? Well, you're probably not surprised that there is a risk of bleeding, with these agents. And what I tell my patients are that not all bleeding events are created equal. If you're a man and you cut yourself shaving and you have to hold a little bit of pressure on the cut on your face for a few minutes while the bleeding stops, that's different than if you were bleeding inside the brain or bleeding internally. So what is the risk of bleeding with being on a blood thinner? Well, if you take all bleeding or all major bleeding, the risk is about 3%. Now, Eliquis or apixaban does a little bit better. The studies have shown a slightly lower bleeding rate of about 2%, okay? But all the others, Warfarin and the other agents, are about the same at 3%. I counsel my patients about intracranial or bleeding inside the brain or inside the head. The risk of that is very, very low, and patients worry about that. And they ask, well, what is the risk? The risk is about 0.3%, okay? With Eliquis, with Pradaxa, with edoxaban. It's a little bit higher with Warfarin and rivaroxaban, okay? Patients also ask about the risk of bleeding in the GI tract, okay? And that's about 1.5% or so, slightly less with Eliquis, slightly less with Warfarin, okay? So when we compare Warfarin with these direct oral anticoagulants, again, the direct oral anticoagulants have slightly less bleeding than compared to Warfarin. So naturally, that begs the question, well, what are the risk factors for bleeding? And so it's things that are not surprising. So really high blood pressure, the top number or systolic number greater than 160. If you have abnormal kidney and liver function, you're at higher risk of bleeding. If you take medications such as aspirin or clopidogrel or NSAID, such as ibuprofen, meloxicam, things like that, your risk of bleeding is higher. If you drink more than 8 alcoholic drinks per week, your risk is higher. If you have if you're on warfarin and that warfarin level bounces around quite a bit, then your risk of bleeding is higher, or if you've had prior episodes of bleeding. Okay? So what do you do? Well, it's easy to know what to do when your risk of stroke outweighs your risk of bleeding. You're going to take a blood thinner, right? And that's what I tell my patients. If your stroke risk outweighs your bleeding risk, you should be on a blood thinner. It's a little bit tougher to know what to do when your bleeding risk outweighs your stroke risk. So that begs the question of, where do these blood clots, also called thrombi, come from? And you heard me mention earlier, rheumatic heart disease, okay? So rheumatic heart disease can affect multiple valves, but most commonly it affects the mitral valve. So in patients that had rheumatic fever and now have rheumatic heart disease, only about half of blood clots form in that pouch, the left atrial appendage. Other half form elsewhere in the heart. So this is a patient that had a valve replacement here. So this is the heart, this is the pumping chamber, this is the top chamber, that atrial chamber, and they have a tissue valve placed here where the mitral valve would be, and this is a blood clot inside that top pumping chamber. In patients that have non-valvular atrial fibrillation, so do not have rheumatic heart disease, over 90% of blood clots do form inside that left atrial appendage. So several of my patients have said to me, well, I have non-valvular AFib. I don't want to be on a blood thinner anymore because I keep bleeding. Can you just send me to have the left atrial appendage removed? And I tell them, yes, that's a possibility, but it's invasive. Generally, we do this during open heart surgery, and the technique can vary. So we can just simply sew that area of the heart, or sometimes we cut it off altogether. And they ask, well, does this work? And the answer is yes. So there was a study that looked at this that showed a lower rate of blood clots being ejected to the body in patients that had their left atrial appendage cut off. Now, again, that is a major surgery. And one of the risks is it can be incomplete in up to 40%. So I tell my patients, unless you have another reason to undergo open heart surgery, I'm not going to send you for a surgical resection of your left atrial appendage. Okay, so if you're going for open heart surgery for any other reason, so you're having, bypass surgery, which we call CABG, or if you're having a valve replacement and you have AFib, yeah, that would be a good time to do it because we're going to be in there anyways. Okay, but what about alternatives to surgery? Well, there are some minimally invasive procedures. Okay, one of them is called the atrial clip device, which I'll show you in a minute. Another is called a lariat device, which I show you down here. And what these procedures are minimally invasive. They're not non-invasive, they're minimally invasive. And they're procedures in which, in this case, what we're doing is we're putting a lasso around that left atrial appendage and snaring it off. This is what's the atrial clip. I'm going to show you a video of what that is. So this is the atrial clip device. This is done through an incision in the side of the chest. And what we do is we put this device around the left atrial appendage that houses 90% of those blood clots, and we put it right at the base, okay? And in doing so, this is a look from inside the heart. We can cinch it off and recreate that surgical technique without opening up the breastbone, okay? And as a result, that pocket, that pouch is closed. It will slowly resolve here. That's the tissue dying, which is normal. And that area is closed off. And as a result, blood clots cannot form in there and they cannot be ejected out of that spot. So what are the alternatives to this? Okay, so now these are minimally invasive procedure. Are there any procedures that are less invasive? And the answer is yes. There are some catheter-based procedures where we go into the veins of the body and do this, similar to if you were to have other procedures like an AFib ablation, okay? You might ask, well, is this similar to stenting? Stenting goes into arteries. These procedures are done through veins. And we'll talk about these different devices. One of them is called the Watchman device, which you can see here, and I'll talk about this in a minute. Other devices are called the amulet devices. And finally, there's another device called the wave press. Now, the only one that's approved in the United States right now is the Watchman. The amulet and wave press devices are still experimental and are being tried in the United States. So this is the Watchman device. It's a cage-like device that gets inserted through the vein in the right leg. The procedure takes about an hour, and the hospital stay is about 1 night. And it's specifically designed for the left atrial appendage. It contains a fabric cap that prevents blood clot from coming out of the left atrial appendage. So it initially acts as a filter. Who do we use it in? We use it in patients that have non-valvular AFib and are at moderate risk of stroke as defined by that scoring system that we talked about. And most importantly, patients need to have a good reason to have this device implanted rather than staying on their blood thinners. So whether the patients are falling frequently, have those Coumadin levels that are all over the place, whether they're bleeding or have a really high risk of bleeding.
But there is a new treatment option that eliminates the need for long-term INR checks and the need to take daily prescription blood thinners. The Watchman device is an implant-based alternative to blood thinners such as Warfarin. The Watchman implant is designed to permanently seal off the LAA, where blood clots can form. The Watchman implant is about the size of a quarter. The implant does not require open heart surgery, and the device cannot be seen outside of the body. As in a stent procedure, your doctor will guide the Watchman implant via a catheter through a vein in your upper leg and into the left side of your heart. Once there, your doctor will release the implant to seal off your left atrial appendage. The whole procedure typically takes less than 1 hour. You would then need to stay in the hospital overnight, and recovery typically takes about 24 hours. Over time, heart tissue will grow over the Watchman implant, and the LAA will be permanently sealed off. In most cases, patients were able to discontinue blood thinners 45 days after their implant. The Watchman implant offers patients with AFib a potentially life-changing stroke risk treatment option, which could free you from the burden of long-term warfarin therapy forever.
So my patients naturally ask, well, this sounds like new technology. I'm not keen on doing something that's new or experimental. And the reason I show you this slide is not to have you read every little thing here, but what I want to show you is that really this device started being investigated in 2002. It was approved by the FDA in 2015. And we at UMass are now actually doing even more clinical trials with this device. So we have been implanting this device since 2016. We've implanted over 250 patients in that time frame. Now, my patients naturally ask, well, does it work? And the answer is yes. There are two large clinical trials that looked at it and compared it to warfarin, okay? And it found it to be similar rates of stroke protection as warfarin. My patients want to know, well, is it successful? And it turns out that procedural success is greater than 95%. Importantly, they want to know, is this procedure safe? And the answer is yes. Over time, since this has been implanted, we've gotten much better at doing the procedure. And the main risk, which is bleeding, the overall risk is now down to about 1%. Most importantly, my patients want to know, if I have this procedure done, can I come off of my blood thinner? And over 90% of their patients come off of their blood thinner at 45 days, and almost 99% come off after a year. Okay. So what do you have to do prior to having this done? We tend to do a CAT scan. So this is a heart CAT scan that we do so that we can measure that pouch, that left atrial appendage, to determine if we can place this device safely, okay? We also do an echocardiogram and to look at heart function, to look at the valves, and make sure that your anatomy or your heart is suitable for this procedure. Once we do the procedure, this is a picture of us implanting the device. So this is that Watchman device closing off the left atrial appendage. This is done under echo, okay, ultrasound. And this is a video of it being done under X-ray. We also like to look at three things in 3D. So this is a 3D picture of the heart. And this is that left atrial appendage, that pouch. And this is it closed with the Watchman device. Importantly, we don't just implant this device and assume everything went well. We watch it through what's called transesophageal echo. So that is like an endoscopy. And what we do is we go down into the stomach and into the esophagus so that we can direct ultrasound into the heart and see this device. And this is what it looks like. We bring patients back after 45 days to do this procedure, this transesophageal echocardiography, to check for a seal. If things are sealed appropriately at that time, we stop anticoagulation, okay, whether it's with warfarin or whether it's with one of those direct oral anticoagulants. Patients then stay on aspirin and another mild blood thinner called clopidogrel, also called Plavix, for a total of 6 months. At 6 months, the patients stop that clopidogrel and they continue on aspirin. Initially, we were keeping patients on 325 milligrams of aspirin daily. We've now dropped that to 81 milligrams of aspirin daily. It's a real team effort to do this procedure, and this is the group of us that perform this procedure together. So Kevin Floyd is the implanter, one of two implanters, along with Glenn Stoken. This is me. I take all the pictures during the procedure with echo. And this is Nicole Navis, who is our coordinator that really helps get all of us in the same room at the same time. She helps coordinate us with anesthesia, and she really is an invaluable resource to all of our patients. So there has been some talk about us in the news. You can read articles in the Sentinel and Enterprise called The Life Changer, the Size of a Coin. The Telegram had an article on us a couple years back about replacing the need for blood thinners. Now, what I want you to take away from this talk today is that blood thinners are still the gold standard to prevent stroke in patients with AFib. If you can take a blood thinner, whether it's warfarin or whether it's one of the direct oral anticoagulants, you should. But these left atrial appendage closure devices offer an opportunity to reduce stroke risk in patients that can't take blood thinners due to bleeding issues, due to ongoing falls, or due to uncontrolled Coumadin levels. In these cases, left atrial appendage closure with a device like the Watchman device may be helpful for you. So with that, I'm going to conclude my talk here. And again, I want to thank you all for joining me on today's video. And again, thank you to Suki and to Joe for your kind introductions.
Another wonderful informational program for you to enjoy. Thank you so much, Dr. Gentile and Joe Fish. Thank you, Rockland Trust, for sponsoring today's programs. The Worcester Senior Center staff sends warm Valentine's Day wishes for you. Stay safe, stay hydrated, and stay connected by watching Channel 192.